there is no better honor than to be asked by a former colleague to come in and participate. Have to understand that Ruth Parker and I go back a long way, and I think it's because of Ruth that I've gotten into this at all. And so thank you, Ruth, and thank you, Terry, and for other people in the room for getting me to think about these issues and to actually actuate some of the things that have happened in my life because of this. As an academic, I am and these are my disclosures, right? Because I'm used to disclosures. Uh-oh, what did I do? I also can't run this. There you go. I'm the campus dean for a new four-year medical college, okay? It's actually accredited under the Medical College of Georgia since the state of Georgia didn't want to have two state medical colleges. It only has one, but decided it would set up a new four-year medical campus in Athens, which many of you will know more about than Augusta because it's the home of the University of Georgia, which is in Athens, Georgia. So I have been there for 6 years, starting from scratch, setting up a new medical campus and being able to, in fact, have my hands on what happens on the curriculum, a very important issue when it comes to things like health literacy. I've also been the chair of the Board of Trustees for the American College of Physicians Foundation, also an important point that I want to make later as we talk about institutions and their influence on what happens in this country. So also as an academic, I need to give you the objectives, you'll give me the objections of my presentation. Okay, so hopefully at the end you're going to be able to compare how nursing, medicine, and pharmacy, my apologies to dentistry, but I'm happy to know that that's going to be taken care of by someone else, have incorporated health literacy or not into their core curricula. To give an example of what we actually do, an activity at a new medical campus, and then consider how changes in the organizational emphasis may change future outcomes, since I am so intimately involved with that. So let's start taking a look at medicine. Okay, often accused as we just kind of were a little bit. Rima did a really nice, gentle job of it, but the obstructions that have come from the educational communities about actually adding something else to the curriculum. So the Liaison Committee on Medical Education is the accrediting body for now 140 medical schools. So 10 years ago it was probably 115. I mean, that's how much we've increased in actually new medical schools. And it's standard 7.8 for those of you who are intimately involved with LCME, and it's called communication skills. And this is what it says. The faculty of the medical school ensure that the medical curriculum includes specific instruction in communication skills as they relate to communication with patients and their families, colleagues, and other health professionals. Now, students, as you know, cannot practice medicine in this country when they graduate. They must go on to residency, okay, for at least 1 year, depending on your state, usually 3 years to become a specialist, but minimally 1 to get a state license. So that means we need to look at the Accreditation Council for Graduate Medical Education, under which, okay, there are 24 sections, I believe there may be 27, but at least 24 RRCs. But this is the accrediting body for all, okay, residencies in the allopathic system. Those of you who follow this will know that by 2020, the entire osteopathic system, their residencies, not their medical students, but their residencies are going to come under the same guidelines and accreditation standards. There are 6 core competencies in graduate medical education, and not at all surprising, interpersonal and communication skills is one of them. And this is how it reads. The programs, no matter what program is, no matter what field it's in, has to have, a program that results in effective information exchange and teaming with patients, their families, and other health professionals. So now we've gone from medical school to having that graduate doctor who will now sit for the end of their licensure at the end of 1 year of graduate medical education, and for specialty boards, with 3 to 5 years. What about my colleagues? Excuse me. So for ACGME core program requirements, so when you actually get down to the requirement, it says residents are expected to communicate effectively with patients, families, and the public as appropriate across a broad range of socioeconomic and cultural backgrounds. And then they must communicate with physicians, other health professionals, and health-related agencies. So now what about my colleagues? How about pharmacy? So this it took me a while actually to find the pharmacy requirements, but from the Accreditation Council for Pharmacy Education, Standard 3, approach to practice and care. The program must impart to the graduate the knowledge, skills, abilities, behaviors, and attitudes necessary to solve problems, educate, advocate, and collaborate, working with a broad range of people, recognize social determinants of health, and effectively communicate verbally and non-verbally. There's a pretty good overlap with that, right? Is there a difference between doctors and pharmacists? Maybe, maybe not, but it's certainly when you write down the standards, it looks pretty close. Well, one more. How about my nursing colleagues? So in the American Association College of Nursing, this is the Baccalaureate Essential number 7, clinical prevention, and it's under clinical prevention and population health. Interesting the way the different health professions actually separate them. And it says, health promotion and disease prevention at the individual and population level are necessary to improve population health and are important components of baccalaureate generalist nursing practice. Do I have any nursing colleagues in the room? Anybody from nursing? You win, okay? Because it's the only site that I could find the words health literacy on the site. All right, and it was under a sample content that could be included in Essential 7. So it wasn't a required element, but it was part of a sample content that an individual school might be willing to do. So what can we take away from what we've just seen? Couple things. In all of the accreditation systems, they give you the competency and the requirement, and each individual school actually writes their own competencies and their own curriculum, linking their curriculum to whatever competencies they set forth that then have to answer the standards. This is particularly true in medicine, and that's because I know it the best. So as we undergo an LCME review, they want to see how my medical college answers their requirements, and they're now listed in only 12 categories versus the former 33 categories. They've just reshuffled everything. And then where our competencies, no matter where you are in the state of Georgia, no matter what campus you might be in or whatever office you're in for a rotation, answers the competencies that the college writes. So that means that if my medical students, if I want to make it a requirement for health literacy, I need to write it in my curriculum that's going to answer a competency to the school that then answers a standard for the accrediting body. So you can see how in the standards, health literacy is almost never actually stated. So the question is, how far have we gotten? Okay, does it mean you can't do it? No. Is it kind of expected? People would say yes. If you go up to somebody and say, well, do you teach health literacy in the pharmacy school at the University of Georgia? I would bet my Georgia colleagues would say, well, of course we do. And then you have to say, and how is it done? And what is it that you do? So I was very fortunate when I came to Georgia to start this campus because one of my youngest faculty was a disciple of Dr. Parker. So Dr. Parker was actually her preceptor in the clinic when she was a resident at Emory. Now, why is this so important? Because she had the skills. Okay, she had the skills. She also had the equivalent of an MPH. Her interest was in community health. She heads up our community health program. And within that construct, she is the person who carries out the initial part of our health literacy. It is not a course. Because in my school, we have no courses. We don't have a biochemistry course. We don't have a physiology course. We don't have a neuroscience course. We don't have a health literacy course. Because everything is completely integrated over the first 2 years, case-based, as well as skill building, as well as community outreach, and working with community agencies. So you can see how health literacy and the fundamentals of health literacy are really important. What else is important in the campus that I've run is core skill building in communication and physical exam. And I'll talk about that as I finish and why and where that influence was in my background. So here are the learning objectives in the first class that we teach in what other people might call our health literacy program. You're going to recognize those. These objectives have been written by most of you. So any of you who have been in the health literacy field, I think you're going to recognize these. So this is what every single student needs to know, okay, or be able to do. And you'll see that not only did you describe what health literacy is, okay, and health numeracy, we actually do, like an OSCE, not an OSCE, but a practice on how you deliver things like percentages and percentiles and make them health literate with people. The teach back in the plain language, and giving them a case scenario. How do they do that? How do they write it? Because what it is from that time on, as they begin their projects in community health, which they have to do in an active way by the end of the year, anything they write has to be health literate. So using the adult educational technique is you can't give it to them once. They have to keep doing it. We have ways of them keep doing it. End of evaluation, since you can't really see this. But if you look at number 6, so every time we do an objective exam with a standardized patient, now for us it's a volunteer, which is even better, because as the students say, our volunteers are more real than the ones who get paid. Most of them being retired professors from the University of Georgia. So if you look at this, this is our communication assessment tool. And if you look at number 6, it says uses language patients can understand. And then that's the domain. And then as you look across, it's the behaviors. Uses some language, which would be unclear to most patients. Uses some language which may be unclear to many patients. Consistently uses plain language. Consistently uses plain language. Checks understanding as needed. So as you see, if we use that same form as we go through all these evaluations, we're continuing to emphasize that this is a skill that we accept. Now, if you look at the rest of the domains, they interact very well with general communication, some of which is, if you look at the literature, what are the criteria for health communication are the same. Patient, allows patient to tell a story, questions and demonstrates listening and attentiveness, facilitates patient's expression as appropriate, treats patient with respect, student nonverbals communicate respect and interest. So most of that I think of as communication. So what's specific about health communication? And for us, it's that using plain language, we make sure that that's going to be assessed. The question of if it's not assessed, will it happen? So that's where that's where the education is. How about the organizational issues? Because this was very near and dear to my heart, and I thought as the education changed, the education of the physician once they leave school and once they leave residency is just as important. And you've dealt with that somewhat here. But I wanted to give you a brief history of the American College of Physicians Foundation because it changed. And it changed because of leadership in times. And I'll make a point about that at the end. So how did the ACP Foundation get into health communication? Well, Dr. Parker, being early on in the formation of this foundation, brought this to the foundation and really got the foundation board to accept health literacy as their core. And that is really very important. And because it was their core business, they were able to help facilitate with the IOM, some of the first conferences. They were able to support some papers that we heard this morning that were very important in moving health literacy forward. But the organization changed. And just like many of us, as we go through our lives and our jobs, sometimes we're doing a good job, but the organization changes, and therefore we don't fit the organization anymore. As the organization changed, they no longer wanted to do this. So with that, the foundation closed, and there's no more core business. And so one of the questions becomes, as we look to the future of health literacy, who are going to be our champions at whatever level? And I think this is really important. So I will just finish with a couple of discussion points. I was thinking about this, and one of the advantages of being later in the day as a speaker is to think about how my presentation fits in with some of the others. So is this really different than I will tell you how old I am, 75. When I was a third-year medical student at the University of Rochester, and Dr. John Romano, the chair of psychiatry at that time, took every student with him to the state psychiatric hospital, where he interviewed a patient. in a very traditional way. And I remember Dr. Romano saying to us as students, the reason I'm taking you to the state hospital is you need to learn that as a physician, you must be able to communicate with everyone, from the farmer that grows corn, to the engineer who always thinks in a black box. All right? That was very powerful as I sat there and watched this incredible person. So what happens comes around, okay? Those early kinds of things are so important. So as I finish up my comments, what are the challenges? There's a system challenge we have. We don't have an educated faculty. I don't have a faculty who can, in fact, did what I did once, and that, Dr. Parker taught us all to do, is to think about, can that patient read? I had and I'll just take up 15 seconds. I had a resident in a MedPeds clinic present me a case. Mother had been bringing the child in over and over again. I asked the resident what was going on. Well, I don't know, because I write out the instructions. It's really very clear. And I looked at the resident and I said, can that mother read? And he looked at me and he said, are you kidding? Of course that mother can read. And of course he went back into the room, and then down the hall, after they were finished with the encounter, I could hear him down the hall saying, shoot, she's right, the patient can't read. I don't think that resident will ever forget that. We need more faculty in nursing and pharmacy and medicine to be able to do that. And there's a confusion, because now the regs all talk about cultural competency, the use of translators, okay, and communication as a whole, but not some of those very fine skills that this group has identified that were very specific to health literacy. Of course there's a big Venn diagram, but we don't want to lose those special skills. So here are the opportunities. We're going to talk about it. Certainly state organizations are coming out. We have one in Georgia. That's great. It's interdisciplinary. Some of the medical schools are not at the table. We're now important doing interdisciplinary professional education. We talked about how, if it's not in the curriculum, it's not going to be done. Well, somehow they got IPA into the curriculum of nursing, medicine, dentistry, okay, and pharmacy, by caveat, no discussion. Okay? So why can't we do that? And my last point is, who will be the champions as we move forward? Thank you.